To Dr. Martinez, I have the question. You were mentioning it could happen that raltegravir monotherapy could be efficient, quite good, very good, whatever. But you were talking about the situation in where you have two drugs, two nukes, but highly resist, and in the presence of high resistance to the nukes. I just want to remind you there is residual activity of nucleosides even if there is high level of drug resistance, and it's not the same if they are not present in the... I wouldn't do it with raltegravir just because Jonathan and Charles were heavily discussing genetic barrier. And really emphasizing, Charles, your concept of a clinical genetic barrier. But I would really say, you didn't go to the end from my perspective. You should address the genetic barrier of the whole regimen, not of single drugs. And then, of course, you have to calculate in this, like adding this, but we should calculate and argue in the way we need to go with genetic barrier in a clinical setting, which is the only meaningful thinking about the whole regimen we are thinking. And this favors, even if you add 3TC to dolutegravir. Just reminding, and this is my last suggestion, we shouldn't forget it's better to have two different targets. The first step, even if you do monotherapy, even if the first step of the virus is very, very small step and it's lowering only twofold, it's twofold less for the whole future in the therapy. And if you have two different targets, you have two different opinions, which is the best first step, and this is different. And in my experience, it works better in long term. What do you say?
So I completely agree with you. There is a residual activity from nucleosides particularly. I do not mean that this is the way we should use raltegravir, certainly. This is not what I wanted to point out. I wanted to point out that even under stressful situations, raltegravir with less than 2 active drugs may work. Just to point out the concept. This may not work for the majority of patients. This may not work for a long period of time, but certainly it exists. So this concept moves us and maybe others to pursue more actively the concept of maintenance therapy with less than 2 drugs, 3 drugs in the setting of integrase inhibitors.
So, Hawk, I think I'll go back to you on this because this is something which I've been thinking about, and our interpretation systems. So you deal with that heavily, Anime's here. I think we may be misleading because when someone does a resistance score, and we give we give a grade to the drug, we're really talking about its ability to suppress viral load, but we're not giving its ability to protect for genetic barrier. Now, I'm not brave enough to discuss this with Bob about our Stanford database because he'll kill me. But in a way, we play around with this a little bit. I mean, just what you said, Hawk, we really want them to leave the Truvada on because it's a big difference. If you give raltegravir without that Truvada, I don't care what the score is, how do we incorporate, and also boosted PIs, how do we incorporate that into our interpretation? Because I think we're missing something. I don't know if you guys are addressing that in your program.
Can I just add to that issue? So you asked me to comment on when you combine drugs, what the effect of genetic barriers. In my talk, I didn't want to make things more complex, but I think there are examples where combining drugs actually get a higher genetic barrier than the sum of the two. So you have a synergistic effect on the genetic barrier. For instance, and I think that's actually one of the reasons for success for Truvada, because if you combine 3TC or FTC with tenofovir, what you get is, in order to fail, you need more than 2 mutations, because the 184V is the first to appear, and that makes it difficult for the virus to break through with tenofovir with the 65R. So that's an example of a synergistic effect increasing the genetic barrier of 2 drugs. And I think that would actually argue for combining drugs in the same target, instead of the argument you're making that you want to address different targets in the life cycle.
Okay, I have to, I admit, but what I should have said, we have to address two different ways of drug resistance pathway. And then we are correct, and we can find it if we are lucky in one target. Yeah, right. Although I wouldn't agree with your example for tenofovir FTC, because it should basically, from the perspective of the virus and of resistance pathways, the same like tenofovir and 3TC. And there's a huge difference in clinical settings and in failure rates with tenofovir 3TC and tenofovir FTC, which is probably based on the differences between FTC and 3TC, which we found and published, and nobody gives so much attention to it, but FTC is more potent. And which brings me back to one point, that the genetic barrier and the drug activity are two complete different things. For example, FTC is more active than 3TC is, but the genetic barrier is exactly the same. For example, raltegravir is highly active, but has a low genetic barrier, and dolutegravir is even more active and stuff like that.
This was the point Jonathan was trying to make, I think, indeed. Let's move on to Andrea.
Yeah, thank you for these very nice presentations. In the context of maintenance therapy, I would like to raise the point in this audience of distinguished virologists about, because it's very nice and very interesting to hear about potency, to hear about genetic barrier, but I would like you to consider one point. So in the last years, large clinical trials has shown us that the inhibition of reverse transcriptase, even by a drug with like 3TC, which has a very low genetic barrier in theory, adds very much to the efficacy of the maintenance range. So think about the difference of monotherapy with lopinavir and dual with lopinavir 3TC. So nobody would have thought that we would have had such a large difference. And think about other trials like the MARCH trial, no? Which is completely different context, 2 NRTIs plus a boosted PIs, and they are switched to Maraviroc plus a boosted PI or Maraviroc plus 2 NRTIs. In the beginning, we would have thought the arm with boosted PI plus Maraviroc would have been the strongest arm with highest genetic barrier, but that went worse as compared to the arm with 2 nukes. So, and look about the dual therapies with integrase inhibitors. If you had an integrase inhibitors with a boosted PIs, yeah, so and so, but with a reverse transcriptase inhibitor, such as rilpivirine or etravirine, as Esteban was presenting, better results. So does it mean that probably there is another component there, which might be linked to the pharmacokinetic effect, the penetration, and so on and so forth, but also theoretically that it's really very important to inhibit the reverse transcription step. So what do you think about that?
You're absolutely right, and you are author of the study with boosted atazanavir plus 3TC, and you mentioned also lopinavir 3TC, and particularly with boosted PIs, we have good data in which dual combinations are not all the same, and particularly 3TC makes the difference. Maybe FTC could also do it. Certainly, these are the data. Maybe, as you mentioned, pharmacology half-life has something to do. Maybe the inhibition of reverse transcriptase has something to do. I do not know, but I think from my perspective in general, in simplification studies, in maintenance studies, that good pharmacological characteristics are the key in many instances. So 3TC has a long life, and maybe this is one important characteristic.
I think the insights will come from the study you're doing in Spain, now comparing dolutegravir 3TC to dolutegravir alone. Because in my mind, what's the added value of the 3TC with the boosted PIs is that in those settings where the PI level is too low, you still have some protection of the 3TC. So it helps to cover the low periods of low boosted PIs. That's in theory. Now comparing longer-acting dolutegravir with 3TC with dolutegravir mono. We will see whether that still holds true or not, and whether you would need that in that setting. Jonathan?
So for Thomas, and then for Janemi. Thomas.
Yeah, thank you very much for the stimulating presentations. Charles, just one point to your intellectual simplification strategy. Do you funnel in at all, because you didn't mention it, Jonathan brought it up, the compartmentalization and the issues of CNS penetration? Because if we have these simple genetic number 3 wonderful drug definitions, this totally goes under. And I think we should at least point the treating physician to, for a subset of his patients, to considering also aspects that have nothing to do with your genetic barrier. Sure. This is why I prefer the term resistance barrier, because it's more complex than just simply saying, okay, let's count the numbers of mutations.
Yeah, so first of all, the presentation I gave was in the setting of this session, and I knew Jonathan was going to follow on no, seriously, that was the way we designed it on PK. And so I didn't want to, my task was really to explain the virological principles. But of course, it's reservoirs and drug levels in other regimens which makes the issue. But I do disagree with you, of course, with regards to the definition. I like the clinical definition of genetic barrier. Tell me how many mutations are required for my drug to fail. And as Jonathan pointed out, it's depending on the drug level. And so you cannot see it in isolation. You cannot do an in vitro selection, show a single mutation, and then make any quotes on your genetic barrier if you don't show the drug level. And then if you project the drug level in vitro, it becomes artificial. So you should look in patients and draw your final conclusions there.
No, just to mention, this is obviously a theoretical concern, and we cannot get rid completely of it. But certainly, virological escape, at least in CNS, has been relatively uncommon. This is what has been published. And particularly, well, this less than 30 cases in the literature, and I have seen directly 3 or 4 cases in my clinic, 5,000 patients. But also maybe that those patients for whom we are trying to maintenance therapy, they are the best candidates in which this kind of risk may be less of importance. And I would like to remind you about the studies with PI monotherapy, particularly those studies at La Paz, Madrid, published in Clinical Infectious Diseases, and the PIVOT study, Alejandro Arenas Pinto, first author, in which they clearly address, in many ways, the issue of neurocognitive impairment in patients with PI monotherapy in randomized trials, and they were not able to see any difference.
Janemi, 3, please.
Jonathan, well, first, the 3 presentations were fantastic. I think it was a very, very nice session. But let me call your challenge. So the original development of the REGA algorithm was exactly to do what you say. So say something about resistance and about genetic barrier. The way we built it was to add a number of mutations into the score, which included also to come to Charles' point, the compensatory mutations. So that you had the build-up of mutations, including the compensatory mutations for PIs then, was actually the genetic barrier built in the algorithm. Now, the reason why it's not like, it's still a little bit, but not really like that anymore, is because of the boosting of the PIs. It was not so important anymore, and because of the subtype issue. Because several of these mutations were baseline mutations in other subtypes. So we became dependent on the subtype in the interpretation, which was not good. But I think you're right, we should go back to that and think back again, how can we, maybe in a different way, implement the genetic barrier into the algorithms. I think you're very right about that.
I think indeed your score does also have that component about and comments, but I'm thinking the context that we made the scores, for example, for darunavir.
Exactly.
There were no integrase inhibitors when we made the darunavir score. It was, and basically you know, at Stanford, when we get to that 60, Richard, you're also here and you've dealt with that. We're happy to hear your thoughts on this. I mean, we want to help the clinician make the decisions, and we've gone over this so much. So we have that 60, that magic 60 on the Stanford score. So if you're giving, if you have a 55 score, you're still giving darunavir, and if you have 65, and that's based on the POWER study, which is not relevant to how we're doing it now, because we're giving it usually to assist dolutegravir in many cases, or to assist another drug. Getting that in, and again, for us at Stanford, the tenofovir score, by the way, Bob has done also work with the FTP3TC, just to mention. I think he also feels that that is not enough emphasized. And going, you know, boy, that tenofovir score we play with so much. You know, we don't want some, is there a way of putting that in the score?
Yeah,
you know,
yeah, let's think it over again. Yeah, and I have another, let's say, a bit of a provocative comment, and maybe apply to maybe some research to what Andrea said, which is the use of RTs. So I always thought, why does AZT work? I mean, considering its potency, you wouldn't think it would really work, but it worked very good. So I really think RT inhibitors, there's something else that doesn't work on RT. And the origin of AZT was an anti-cancer drug. So I think if you see now what the things that we start to see about clonal expansion in HIV, which I used to think of already for a long time, because in HTLV it's standard, but we see more and more issues on clonal expansion. So who knows, maybe let's say the toxicity of the RT drugs does something to help somehow. I don't know, maybe it's a point for further research.
There, I think I was struck yesterday by Behrens' presentation on the start, where he showed that the effect of early therapy was not reflected in CD4 and was measured basically by neoplasms in the end. So I think we should rule out former anti-tumor activity of the RT inhibitors contributing to some of the effects. But it becomes much more relevant now we start to treat earlier and longer.
I think here we had Richard's hand.
Yeah, coming back to this definition of genetic barrier or resistance barrier, some years ago, if you remember, we had this discussion already, and it is difficult for us to understand, and we can quite easily understand number of mutations. But Nico Bärenwinkel just studied the time of failure for each drug, and that also explains why such a drug like efavirenz was so successful, even there was only one mutation needed to make full resistance. But coming back to this objective that we can really investigate the time until failure makes it comparable, the different drugs, but for us virologists it is a bit uncomfortable because we don't know really the mechanism of that. And it is even more complicated because we look on combination therapies. So what we should try to come back is investigate our databases and calculate the time of failure for each drug combination, and maybe we come to a better conclusion by that way.
That's quite interesting to do. I think what you will find, if you, but I'm just predicting that it's then becoming a function of the variability per se. So how many of the variants were there to start with? And it's also a function of the replicative capacity of these viruses, and perhaps in addition some others. But it would be interesting to see the data if they come out. Microphone one.
Maybe I have a bit out of box and a challenging question, but regarding the future of the long-term maintenance therapy. So what you think that why we don't have these kind of drug, which is a completely new class? Because the point is that currently available HIV drugs, none of them inhibit transcription and the proviral DNA and further translation into the HIV proteins, which means that actually all patients, HIV patients, have low-level expression of HIV proteins which cause immune activation and harmful effects of bystander cells. But the HIV has 16 proteins and one of them is small TUT. TUT is a transcriptional activator. Why TUT is not so far used as a drug, as a target for drugs? For instance, I know that REF is one target, but for those patients who need long-term maintenance, what is your opinion? If you could have at hand potent inhibitor of TAT, how would you comment that?
Yeah, I think now we basically, that's I think the discussion Jonathan started with regards to biomarkers, right? I think what we will find is if we're going to do this, hopefully what we're going to find is we're going to do what we call maintenance, but what I think is just novel hard, that we're going to focus on the reservoir, how do we measure the reservoir, and how do we measure inflammation. And I think tomorrow there's a discussion on the tools that we use in cure, and I'd like you to specifically pay attention to the tilde assay, which is a relatively easy assay which allows us to quantify the numbers of cells that still have virus in there that actually can replicate, which is a much finer tool than just measuring proviral DNA, etc. So I think the tilde assay and measuring cellular RNA will help us to start to address your questions and to see whether indeed inhibiting TAT is preventing production of viral particles, or for viral proteins, is preventing inflammation, activation, etc. Future research.
So maybe Annemie, a final comment?
Actually, I have an answer to the question of TAT. So what actually has been done, everybody is looking for decades for a TAT, a good TAT and a good REF inhibitor, because you can do it on both levels, TAT and REF. And basically they are all too toxic. We tried and tried and tried. We have a special line doing nothing else than that at the Rega Institute, and it just doesn't work. They are too toxic because they interfere with a lot more than just HIV replication. Some of these drugs are actually now being developed as anti-cancer drugs.
So I think we're going to close. Charles has some housekeeping. Before that, I'll thank Esteban and Charles, and I thank all of you for, I think, a great session, and hand it over to Charles to close it up.